Welcome to this episode of Conceptual Anesthesia. So, we'll be talking about status epilepticus. So, since the time we were doing MBBS and now post graduation, we've been talking about seizures and status epilepticus. But the more you move into critical care, the more you realize that status epilepticus has also been evolving like us. So, it was status epilepticus before, then there comes a terminology called refractory status epilepticus, then super refractory, then new onset refractory. So, what do we mean by all of them? What is their significance? And why are they important to us? And how we can actually manage such a patient in the critical care setting? This is all that we'll be talking about today. So, remember the diagnosis of a convulsive status, that is status epilepticus, mostly clinical. So, it is defined as more than 5 minutes of continuous seizures. That means there is no recovery in between. The seizure is continuously going on for more than 5 minutes, or more than two discrete seizure episodes between which there is incomplete recovery of consciousness. So you had episode of seizure, the patient was still drowsy, and within few minutes he had another episode of seizure. So that means the seizure is not settling down, it's gone into status epilepticus. Now International League Against Epilepsy tried to define that. So they wanted to define what do we mean by status epilepticus, and different types of seizures are there. So how you can define status epilepticus with all those subtypes of seizures. So they tried to define a T1 and a T2. So first T1 is the time at which ongoing seizure activity should be regarded as abnormally prolonged, unlikely to stop spontaneously, and when treatment for status epilepticus should be started. So that means the patient is having a kind of seizure and the activity is prolonged enough for the doctor or the medical person to realize that it won't stop spontaneously and we need to treat it. So that is T1. And then T2 is the time after which the ongoing seizure activity poses a significant risk of long-term complications. So for generalized chronic status epilepticus, they propose T1 and T2 as 5 or 30 minutes. So as I told you, GTC has 5 and 30 minutes. So T1, as I said, beyond which a seizure is unlikely to spontaneously terminate, you have to start treatment. And T2 is that beyond which neuronal damage may occur, you have to be very aggressive in treatment of these patients. So for GTCS, T1 is 5 minutes, T2 is 30 minutes. For focal with impaired consciousness, the T1 you have to start treatment is 10 minutes and T2 is probably more than 1 hour. For absence seizure, T1 is more than 15 minutes. So you absence seizures, you normally diagnose it by a EEG or something for more than 15 minutes and T2 is probably never. So you have to remember for GTCS 5 and 30 minutes, that is the classical definition. And what does T1 and T2 stand for? Okay. Now all of you know a difference between a seizure and a pseudo seizure. So remember, a seizure usually the cause is absent, whereas a person who's malingering or having a pseudo seizure, they might be emotionally disturbed. The patient may have palpitations, malaise, choking, that is what they will tell you. And these are the warning signs of a pseudo seizure. Seizure is always sudden, and if the patient is screaming, they scream during the onset. Whereas in pseudo seizure, because it's because of emotional disturbance, the onset is gradual and they scream during the course of the pseudo seizure. The tongue bite is very typical of seizure, whereas in pseudo seizure, the lips, hand, or more often other people and things can be bitten. A very peculiar thing that you need to ask whether the patient by chance had defecation or micturition during the seizure, because it is very frequent or occasional in seizure, whereas in pseudo seizure it never happens. There is no history of passing of urine or stool during the seizure. And the termination of seizure usually is spontaneous, whereas pseudo seizure, if you throw water on the patient, it can suddenly terminate the pseudo seizure. The duration of seizure is a very few minutes, whereas pseudo seizure is often an hour or several hours. So just to be sure that you are dealing with a seizure, that is why I tried to put this definition here. Now this is defined around three things, like in convulsive status epilepticus, repetitive tonic-clonic movements occur followed by a post-ictal state. Post-ictal state is usually of confusion. Then there's a epilepsia partialia continua. So as I told you, a partialis means there is only, it is not a generalized tonic, it's a focal neurological deficit such as aphasia and motor dysfunction occurs as a result of partial seizures. But usually the patient's mental status is fine and altered mental status is not present. In continuous or fluctuating mental status changes, this can occur in NCSE, non-convulsive status epilepticus. So these are the three subtypes of status epilepticus: a convulsive one, a partialis continua epilepsia, and a non-convulsive status epilepticus. Now, as I told you, an episode continuing clinically and or on EEG despite administration of two anti-seizure medications is called as a refractory status epilepticus. So when we were undergraduates, we heard about status epilepticus. Now we'll heard about term called as refractory status epilepticus. So that means either clinically or on EEG, the seizure activity continues despite giving two anti-seizure medications, including one of a benzodiazepine, which is usually the first medication that you give in the seizure. This patient is labeled as refractory status epilepticus. Super-refractory status epilepticus is if the seizure is continuing despite at least one course of anesthetics. So I'll be telling you when do we give anesthetics. Then there's a terminology called as New-Onset Refractory Status Epilepticus, NORSE. So this occurs in previously healthy individuals lacking an obvious acute, structured or toxic metabolic cause. So usually what happens when a patient comes to you with seizure, the patient may have some structural damage in the brain or there can be a toxic metabolite which is causing the seizures. But a NORSE patient usually is healthy and does not have a proper cause which can cause the seizure like structural or toxic metabolic cause. And this includes a particular subgroup which we called previously as FIRES, febrile induced refractory epilepsy syndrome, which was initially described in children, but now it can occur at any age. So this refers to occurrence of fever preceding the status epilepticus onset by 1 to 14 days. So this is, if you see now many patients in the ICU and many case reports and studies are being done in NORSE and FIRES in adults. So the incidence of status epilepticus follows a U-shaped distribution. So it usually U-shaped is bimodal. So one is less than 1 year of age and other is older over 60 years of age. And over a lifetime, up to 10% of adults with epilepsy and 20% of children with epilepsy will have one or more episodes of status epilepticus. So when you have a person with epilepsy, you have to counsel him and tell him that he might have a chance to go to his status epilepticus if it is maybe caused by a fever presiding or some new infection or some new insult, but they have to rush to the hospital immediately. And as I told you, the overall case fatality rate appears to be close to 15%, with a greater mortality in elderlies and in patients with refractory status epilepticus. So, what is the etiology? So, most cause of status epilepticus in adults are due to underlying structural brain lesion or toxic or metabolic disturbance. So, when I told you about NORSE, that means these major causes are absent in them. If the underlying medical or structural causes of recent origin, status epilepticus is told to be provoked or acute symptomatic. So person may have a structural issue, maybe he's had a head injury or a stroke and then he has seizures. That means it is provoked or acute symptomatic cause for status epilepticus. Many episodes come from a combination of an earlier lesion over another lesion. So a patient may have a previous lesion and then he has a metabolic infectious or pharmacologic stressor such as uremia, like a patient develops, a old patient of SDH who has been operated long time back, now develops CKD and he develops uremia and he has seizure. Now, acute structural brain injury can be because stroke, head trauma, subarachnoid hemorrhage, cerebral anoxia or hypoxia. Any kind of infection, encephalitis, that is the infection of the brain parenchyma, meningitis, a brain abscess or a brain tumor. Stroke is the most common cause, especially in older patients. Then remote or long-standing structural brain injury like previous head injury or neurosurgery, cortical malformations, AV malformations and low-grade brain tumors.